All right, what are some other, here's a few other examples to threats to validity. All right, so here you have an investigator studying the effect of continuous positive airway pressure, or CPAP, initiation in parturients with sleep apnea on peripartum complications. And looking at, uh, and, and they found that there was a higher attrition rate in the control group compared to the treatment group. So this was at the conclusion of that study. So what type of threat to internal validity do you think is occurring in this study? All right. It is mortality. So what happened is you had a higher attrition rate during the study, and that could potentially impact the outcome because maybe the group that the subjects that are left in the study at the end, maybe there's differences between the groups, between those who completed the study and those who did not. And so the investigator in this study, in their conclusions or in their manuscript, would need to make sure they address those, or sometimes they'll even do post hoc analyses. They also may do what's called use an intention to treat protocol, and we'll touch on that in later weeks. Okay, another question here to think about, a threat to validity. In the same study, the investigator discovers after study completion that the obstetricians started sending patients in the control group for a sleep study referral and CPAP initiation. And he finds no group differences when he analyzes the data. And let's just assume that he had an appropriately powered study, had enough subjects in the groups to detect differences. So what type of threat to internal validity do you think is going on here? History. So there's something that went on that was maybe at this time was unbeknownst to the investigator, that just naturally occurred. And this is not uncommon in studies where you're looking at interventions. Is what happens is, maybe especially in a teaching hospital where I was from, that they start learning about what you're doing and think, oh man, that's cool, I think that's really going to be beneficial to my patients. And you get you get staff that start actually using an intervention, um, and that, while that's probably good, potentially good medicine if it's really something that may work, but it can impact your study findings, because now your groups are, you're losing some control over the study. All right, the next type of validity that we'll talk about is construct validity. So what are constructs? These are just abstractions that are deliberately created by researchers in order to conceptualize a latent variable. Latent variables are not directly observed, but we infer them from other variables that are directly measured. And so a construct validity is the degree to which a group of variables really represents the construct to be measured. And it's a psychometric tool that we use to help determine if an instrument measures what it is supposed to measure, which is validity. And so I've included a copy in this week's, it's in your list of articles to read, and this one's going to be part of the discussion question. But I want you to take a look at this article that looked at patient satisfaction measures in anesthesia. This particular article has a nice introduction and review of different type of psychometric properties, including construct validity, as well as talking about a number of different patient satisfaction measures. I'm not necessarily concerned that you read in great details these different measurements, these different tools, but I want you to really read this article to help you understand the concepts behind construct validity and really psychometric properties of instruments. All right, now external validity. External validity is the extent to which our research findings can be generalized beyond the sample to the population of interest. And the more the sample is like the time, place, setting, and people from the population, then the more generalizable the results. And so there's always this yin and yang between internal validity and external validity. Studies that have really strong internal validity oftentimes are not really that generalizable because we're trying to take those study findings and generalize them to a larger population, but we were so inclusive, or maybe our inclusion criteria was so specific that it doesn't look like the larger population. Or a problem is sometimes is maybe you read a randomized controlled trial results and it was done in a particular setting, and it's done a unique way, and then you go implement it at your institution, it doesn't work. And one of the factors is maybe it just was not generalizable because it only had an impact on that particular sample. So let's go through some examples of external validity. So a DNAP student surveys CRNAs at a single large academic medical center on their frequency of call shift fatigue. So the question I have for you is, can he generalize his results to CRNAs that work in rural critical access hospitals? If you need to pause the video, you can and think about it. All right, so he's looking at a large academic medical center and trying to make inferences to a rural critical access hospital. He's trying to generalize those results. Well, in fact, no. This study would actually have low external validity because it was just done at a single large academic medical center. Now, you could potentially make the argument that maybe the results are applicable to CRNAs at other similar large academic medical centers, but certainly not to rural critical access hospitals, because there certainly would be maybe differences in how call is taken. All right, what about this study? This abstract here that I pulled it up on PubMed, labor epidural analgesia in Poland in 2009. It was a survey study design. Can these study findings be generalized to other countries? Well, the answer would be no, unless those countries looked just like Poland. You certainly could not generalize these findings to the United States, where I would imagine our analgesia options for labor are probably much different. Here you can see that they're talking about a use of Intox was used very occasionally, but the most common means of pain relief was pethidine, which is a type of pain medication. And so that just gives you an example of how sometimes it is difficult for us to generalize study findings. So we're looking at external validity. Like I mentioned, external validity looks at if it's looked at studies with strong external validity have a very heterogeneous sample. Maybe they sample from multiple locations. Where they collect data from multiple different places and across different times. Whereas studies with strong internal validity, one is that they can randomly assign participants to groups, and they very tightly control the conditions under which the outcomes are studied. And so you can pause this video and read a little bit closer to the comments on there to help you understand the differences between internal and external validity. All right, this figure here is taken from Dr. Biddle's book on page 45, Evidence Trumps Belief. This is the second edition. And there is very much a balance. So when we think of internal validity, we think of experimental rigor, where the study is very tightly controlled, and we're really trying to isolate the effect of the intervention on the outcome. So that really requires tight control of the patient, setting, and interventional factors. And our emphasis here is on tips the balance in favor of internal validity. So increased control, unfortunately, means decreased generalizability. However, if we want to are results they apply to a broad population and be generalizable, then we need to have less control over the study. Um, and unfortunately, that can sometimes lead to biases in the results. So if you increase the diversity of patient application, requires relaxing the entry and experimental control criteria to some extent. So good studies design controls either for, or maybe they control the environment. They have controls set up to make sure that there's equivalence between the subjects in the two groups, so that there's no differences in, say, baseline demographics, how the intervention is applied, how they measure the outcomes, and they control for extraneous or confounding variables. So I'm going to pause there, and you can continue watching the lecture or listening to the video here in just a few minutes.